Morning. Thank you very much. I'm very pleased to be back in India. My brief today is to discuss with you the OOKP, and I thought I'd just step back and share a few thoughts with you. So why are we here? I think there are three possible reasons. You may have a general interest and you want to find out more about keratoprosthesis in general and the OOKP in particular. You may have a specific interest in that you may have a patient or patients you wish to refer, or you're considering learning and offering OOKP surgery. Or, like me, you may already be a K-Pro surgeon, and that's we're assembling as part of the K-Pro surgical community to share experience. So what is an OOKP? It stands for osteodontal keratoprosthesis, which immediately tells you that it's to do with bone, tooth, and artificial cornea. And here it is in its full glory. On the top left you see the clinical appearance of a completed OOKP eye, and on the bottom right a cross-section which shows you that the eye has mostly been hollowed out and that the optical cylinder through which the patient sees has been surrounded by a picture frame of bone and dentine, all of which has been shrink-wrapped with thick buccal mucous membrane. So, who requires an OOKP? Patients with bone-dry eyes, bilateral corneal blindness, or those, even with a wet eye, has a defective blink or deficient lid. So essentially, we're bypassing the ocular surface and the cornea altogether. And how about who should not be offered an OOKP? Well, those patients who are young, because we have found that patients below the age of 18 will have the OOKP lamina resolved rather quickly. Eyes which have poor vision potential, eyes which still have continuing ocular surface inflammation, smokers because a free graft will probably not take, and various psychological reasons. For example, those who are very happily adjusted to blindness, those who are unwilling to travel, or those who are unwilling or unable to accept risks of complications or poor cosmesis. How does it work? It's a system of deception, essentially, because if you put a plastic implant in the eye or on the cornea, it will gradually extrude through having a fibrous capsule. However, if you surround it progressively with dead, hard dentine, coupled to living porous bone, which in turn is shrink-wrapped by living mucous membrane, which gives the bone a blood eye, then the eye is deceived into accepting this. How is it done? Through arduous labour, multidisciplinary approach, and various stages, at least 2 stages, and different teams in the world have divided these stages into smaller sub-stages. So there could be 3 or even 4 stages, depending on which centre you go to. But essentially, it involves harvesting a tooth and the surrounding jawbone and fashioning that into a plate through which an optical cylinder is cemented. Every step is important in that if you don't do each step properly, then the risk of complications are much higher. At the same time, in stage 1, the scar tissues on the ocular surface is removed, and you place a large piece of buccal mucous membrane over the eye, and that gets a blood supply and gradually sheds the old epithelium and grows new epithelium. If everything is fine, then you carry out stage 2 after 2 to 4 months, and basically you take the tooth plate back out, examine it, and make sure it's large enough. Take the excess soft tissues off, and similar to the Pintucci, which your President-elect described earlier, the mucous membrane is reflected and a hole is made through the cornea. The iris is removed, the lens is removed, and there is a very big open sky vitrectomy carried out. And then the device is put there on the surface, and mucous membrane placed over it to protect it. So who does OKP? There are centers worldwide, there are centers in Asia, and there are centers in India. So in Europe, there are various countries. It originated from Italy and it spread to other countries, including England, where I work. The Americas, Miami, I believe, has done a couple of cases, and I think my teacher also set up a center in South America. In Asia, various countries. In India, this information from Radhika Tandon, and you can see that there are a large number of K-Pro surgeons, and half of whom also offer the OKP. And colleagues here have done large numbers in relatively short number of years. So, should I offer OKP? Should you offer OKP? Well, if there is a need in your country, and if you meet the person and institution specifications, and you do need to be totally dedicated for any, if you want to offer any kind of keratoprosthesis, because they need you. These patients need you anytime, anywhere. So I think we need to be aware that proliferation of units will dilute experience unless there is a huge need in your country. And the specifications are that you have a dedicated team and a dedicated leader, and your hospital have to have a full range of subspecialist consultants, etc., and easy access for your patients. So what about the results of OKP in terms of vision, retention and complications then? Well, these are Falcinelli's results in years, and nobody can match those. But as rules of thumb, you can probably quote over 95% anatomical success if you exclude the smokers and if you exclude patients who have continuing ocular surface inflammation. And between 2/3 and 3/4 will have visual success, which will last for many years. However, if you need to borrow a tooth from a relative, then it probably wouldn't last as long. And patients can expect to have complications requiring further surgery. So what are the complications? Laminar resorption. This is not entirely predictable, but if there's ocular surface inflammation, then there will be more laminar resorption. Larger teeth and thicker laminae to begin with will be advantageous. Clinic examination every 3 months when they come back, and annual imaging will be useful, and Fosamax may also be useful, and ultimately we'll have to replace the tooth and bone with a synthetic OKP lamina, which various groups in the world are working on. Oculoplastic complications. The mucous membrane can ulcerate or necrose at different stages. If it can overgrow onto the optical cylinder, there would be various lid malpositions and phonocyl shortening. And of course, with the extra bulk of the tooth and the mucous membrane, the eye will look bulgy. And of course, it's very pink in appearance, and most young people may find it cosmetically quite unacceptable. Glaucoma, you've already heard about from my colleague Venkata Avadanam, but what we found in the last 17 years is that intracap is better than extracap in terms of glaucoma incidence, and the prior penetrating keratoplasty may be a factor in causing de novo glaucoma following OKP surgery. So for bone dry eyes, there's no need to try and wait for a PK to fail before offering an OKP. Vitreoretinal complications, patient education is most important, and if there should be endophthalmitis, and there usually isn't unless the lamina is already resorbed, then they must present very, very quickly. And if there was a retinal detachment, equally they must present quickly, and we can repair using the biome or endoscopic system. And silicone oil can be used, and they can still have useful vision afterwards. Optical cylinder design, we're constantly working on to improve the field and reduce glare. The psychological complications, we have a clinical psychologist on board, and she has a role in the initial assessment and provision of support throughout the patient's journey, and whether it's threatened or actual failure of device. So these are the various things that patients may be thinking of in their mind, and we need to be aware of that. And for those without teeth, it is more of a problem. An allograft doesn't work as well and requires immunosuppression, at least to begin with. Tibial bone doesn't work as well. Pintucci, you've heard about, and there's of course the Boston Type 2 K-Pro, which Professor Chodosh is working on. You've heard about the Pintucci K-Pro. These are the original Boston Types 1 and 2, and Jim Chodosh's name has been mentioned as Professor Dolman's successor 3 or 4 years ago, and here's the latest click-on Boston Type 2, which is being worked on. The future prospects of patients requiring a keratoprosthesis for dry eye, I think the importance of buccal mucous membrane cover for dry eyes is now fully recognized, and I feel that the Boston Type 2 and the modified OKP will morph into a unified epicorneal device with mucous membrane cover, and the OKP will become synthetic. So remember, we're a community. The revamped K-Pro study group will be back on the website soon, and I'm very hopeful that we can also have an OKP users group. Remember the concept of renewal and regeneration. With age comes experience and wisdom, and eventually we also become older, and we need to be aware that we need to continue to learn throughout life and teach and share our experiences. I pay tribute to my teacher, Falcinelli. I pay tribute to my family, and I thank you for your consideration.